Welcome to Black Health Matters. I'm Daryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
Turner, who was one of our former residents, who's already the executive director of the American College of Surgeons. She's the first woman who's ever done that. Now she's president-elect of the Council of Medical Specialties, just to show that women are taking over everything, everywhere. Is that good or bad, or
That's a good thing.
It's a good thing, huh? Okay. Yeah, well, she's doing a great job so far. And it's great to see people who have trained to become so prominent and successful. Let's go to the next one. I wouldn't dwell on that. Then, of course, this is the first surgeon to lead NIH. She was leading the National Cancer Institute of Health, and now she becomes the first surgeon to lead NIH. That this approved finally, and first surgeon, and the second woman, actually Bernadine Healy, was the first woman, but many years ago. So it's interesting to see that how far we've come and continue to move forward with forgetting about gender and recognizing how important diversity is as we move forward. Okay, let's go to the next one. It's interesting. Most of these organizations have always been run by men, and so and it's different. It's interesting that if you in many organizations, if you need something done, you go to one of the ladies there, and they take care of it. But yet, in spite of that, there've been so few women who've actually been in charge, and so things are turning around for the better. This is an interesting story about a doctor who was running a marathon himself, and had actually a month earlier been involved in a malpractice case in which he was found guilty. And he was pretty devastated, and but he was running the race, and about halfway through, there was a call for help, and it turned out somebody had, as Daryl has mentioned earlier, with marathons, somebody's always having a cardiac arrest, and this lady had a cardiac arrest and was dying. He intervened and helped resuscitate her until they could get a defibrillator. After the fourth shot, heart came back and she started breathing on her own, and she went to the hospital, and actually, even though the heart had stopped in 20 minutes, we were able to resuscitate her. And of course, it was difficult for him, but he then went back and finished the marathon. But the other thing that happened is interesting that after he did all this, he then was recognized as a hero. And then finally, the malpractice case that he was accused of was actually settled in his favor. So, but what is interesting is the devastating effect of having a malpractice suit go against you when you feel you've done nothing wrong. And it does depress you and make you wonder whether you're in the right field or not. And he um, went through all that agony and was self-doubting himself. But this situation brought it back to focus of what he was in medicine for, to help people, whether people recognize you or not. And so I thought it was a very great story of somebody who was able, in spite of the fact that he was devastated and depressed by having a malpractice suit go against him, still did what he was trained to do and saved a life. And lo and behold, things turned around in his favor. Uh, but just to show you that when doctors have malpractice suits against them and they lose them, it is a depressing and devastating effect upon many doctors. Some doctors actually stop practicing after that because it's such a devastating. You hear so many awful things said about you during the course of the trial. Uh, so, any comments? It's an interesting story that rings true because it talks about the ups and downs of medicine and how sometimes you don't feel appreciated even though you are.
Yeah, I think
Any
it's
com-
wonderful that his training kicked in, and he should be proud of that. But the training uh, that we often don't, most of us don't get, is training not to take ourselves too seriously, and
yeah.
training that you are not your job.
Yeah, that's right. Yeah. Yeah, yes, I try to train my students to understand that what is important is for you to do the very best you can. Once you've done that, that's your responsibility. Give it the best you can, and give it your best every time. And the rest is not determined by you, although you think you think it is. But give it your very best, and I think that's what is asked of you. But you're right. I think you're right. People do take themselves too seriously often, forgetting that uh, uh, the way things turn out have many complicated aspects of why they turn out the way they do. And those who actually uh, have faith and believe in God recognize that uh, all things happen for a reason, and sometimes what you think is not so good is what is necessary to move things forward. And so that's the great advice that you gave, Daryl. Yeah. And
What
if you can't laugh at yourself, then you can't be yourself.
Dr. Callender, what interests me is that what doctors do is called a practice, you know. They have a practice. In music, as we know, we say that practice makes perfect, and perfect practice makes perfect. So how did how did that word practice come into the field of medicine?
Well, it is thought that actually medicine is an art. It's an art, and the term practice is not meant uh, in the same way you use practice in medicine. Although in medicine we try to learn from every mistake we make so that we can become the best that we can be. But it, I believe that practice makes perfect in every field, medicine, science, every field. And it's interesting. There's a lot of different perspectives on it. I think was it a musician or an athlete who said that actually uh, the person who practices to make no mistakes or practices to be excellent is not as good as the person who practices not to make any mistakes. Uh, Practice makes perfect, as you said. When you really are at the top of your game, you really uh, practice to ensure that you make no mistakes. But you know, it's all a play on words.
You remember when you used to practice your foul shot back in New York?
Still do,
Mhm.
but I couldn't get 100%. You know, some people can shoot 100%. I had trouble getting above 80%. Yeah, so that was not my greatest gift. Although I loved it and it was fun, but I just wasn't that good at basketball or baseball. Now this is a breakthrough that hopefully will make a difference, but it's kind of scary though. AI detects hidden, potentially curable pancreatic cancers, and what they did was they took all these scans and got humans to read them. Then they got AI to look at the scans and read them. And they were able to identify that with AI, they were able to pick up cancers that many doctors were unable to pick up, which is an interesting finding, suggesting that in the long run, AI may be even better than all of the experience that we have. And that's what this study is all about, that using AI may be able to pick up the early pancreatic cancers when they can be treated. And as AI takes over almost everything else, it's going to take over many aspects of medicine, and radiology, maybe an additional one. Of course, we already have robotic surgery, and now we're getting a situation where there's evidence that AI can read X-rays even better than humans can. So, but this becomes important because pancreatic cancer is the cancer that we're least able to diagnose early and least able to cure. But if you could pick it up earlier, maybe we could cure more. But that's what this study is all about. So that's now. This has not yet been put into practice, but something that is likely to occur in the near future. So yes, there'll be radiologists, but you also have AI looking over the shoulders of the radiologists.
Dr. Callender, do
Yes,
they um have to do a biopsy on the pancreas?
if you find a tumor, yes. If the X-ray finds a tumor, yes. The only way to know it absolutely is to have a biopsy.
But how would you? Why would you have an X-ray?
If you have
Okay.
pain or you have any symptom, diarrhea or any symptom that is unexplained, then very often the regular X-rays, in some occasions, don't pick it up. And so if you're asymptomatic, it's not something that you would generally do. But if you were symptomatic, having pain or diarrhea or discomfort in the abdominal area that was unexplained, then this would be why you would get the X-ray.
All right, thank you.
And this is the one disease for which we haven't made a lot of progress, pancreatic cancer. For many, by the time they make the diagnosis, it has already spread. And so many of these patients who have the diagnosis are dead within 6 months. So that's why the great interest in making a diagnosis early and what's treatable and why surgery can be done and cured. Nowadays, the 5-year survival rate for pancreas cancer is probably more like 20%. So we got a lot of room for improvement with pancreatic cancer. Okay, any other comments? If not, go to the next one. Now, this is something that surprised me. I wasn't aware of the role of AI companion robots, but this is an article about a lady who had her robot as her companion. And I don't know anybody else know about people who have robots for companions. She'd lost her fiance and her dog and felt very lonely. You know, many people who don't have friends, they have dogs. And then when they lose the friends and the dogs, then they become very lonely, depressed, and have nothing to live for. And so if you don't have a social group, then companion robot seems to be the option. Any comments on this? That's new to me.
Yeah, it's kind of like Star Trek, where the robots were RTD2, and they were
Yeah,
like people friends in the movie.
yeah. I think Star Wars. Yeah. They were. You thought of them as real people, even though they were absolutely.
I,
Anybody else have experience with this?
Dr. Callender, I saw on TV, I think last week, where some organization is giving away robot pets to people with dementia.
Okay, all right. Robot pets, huh? Okay. Well,
Right, to keep them entertained
okay.
and interacting, and that they can't have real pets because they can't take care of themselves. But
Right.
I think that's what that is, that picture.
Yeah, that's true. You know, if you're wheelchair bound, it's pretty hard to walk a dog. I mean, to really care for an animal. I don't know about cats. I don't think people walk their cat, but if you have a dog, you have to walk the dog. You got to take them out, and if you're in a wheelchair, that might be very difficult. So, but the robot pets seem to serve that role as companions, and they respond to touch, and they purr, things like that. I mean, they're in.
Yeah, it seems
I,
like
th-
it's a great idea.
I think this would be great for people suffering with CRS.
Right.
That's
What's
can't remember
CRS?
shit.
What?
What is
People
CRS?
suffering from CRS, that's can't remember shit. Like
Oh,
when you walk into a room, you just ask your robot, why I come in here? And the robot said, to get your keys. He said, well, where are my keys? On the table. So it'd work out great.
That's like I
what?
was surprised. I'm sorry.
No, I was just gonna say, isn't that what Siri does? That's just a that's just the beginning, that Siri thing or Alexa thing.
That's exactly what I was going to bring up. Thank you. Very
business.
well. And a lot of people are into those
She doesn't
things
mind her
now.
business.
Mm-hmm.
Yeah, she's
Companionship. Yes.
yeah.
Little girls have doll babies that can talk and stuff to you.
Yeah. Well, this is interesting how our future is going to be. Yeah.
Just hope your dog doesn't bite anybody.
Well, these
I
robots.
have to go to court.
Yeah. Okay. Well, that's another use for robots. So I think it makes sense because it's all about having companionship, and that we're social animals. If we don't have companionship, we sometimes cease to exist. Okay, let's go to the next one. This is good to know. This is an article that talks about the fact that keeping your blood pressure normalized reduces the likelihood of you having dementia. We know there's so many different causes of dementia. Alzheimer's is one of them. There are many other forms of dementia. But one of the things that we can take care of, we can control our blood pressure. And of course, this requires us to monitor the blood pressure at home. And this study demonstrates the benefit of normalizing the blood pressure. In those patients who was normalized, the risk of dementia was decreased. And so it's just another good reason why monitoring and controlling the blood pressure, keeping it as close to 120 as possible, is good for many reasons, affecting the heart as well as the brain. I guess it's no surprise, but it's an interesting observation. Any comment about that or any discussion? Still, the group of patients who have the highest blood pressures are those people who are on blood pressure medicine but don't take them regularly. So it's important to be sure that if you have hypertension, that you are monitoring it and making sure that your blood pressure is controlled, because just because you're taking blood pressure medicine does not mean that your blood pressure is controlled. And that's why it's so important that everyone should have a blood pressure apparatus at home so they can monitor their blood pressures.
Dr. Callender, I came to a point where I have to make a decision whether to continue taking losartan or stop taking losartan. I do take a couple of other blood pressure medicines, hydrochlorine and metronidazole. So I think I'm gonna ask my heart doctor.
That's what he's for. That's why he exists, for you to talk to him and decide which blood pressure medicine. What kind of blood pressure do you run?
Mine is always excellent, like under 120. It's like 115, 110.
Oh, wonderful. That's great. Okay. Yeah, well, that's a good conversation to have with your heart doctor, because you have that's the ideal, is to have the kind of blood pressure that you have. and keeping it that way is what matters. So when you and your heart doctor have the discussion, the question is, how do you keep it that way? And what medication is necessary for you to keep it that way? And do you need all of those medications or not? So, and the fewer medications you need to take, the better off you are. Okay, it's pretty straightforward. I guess this is something that we've talked about for some time, that older patients should be on only on the medication that they need to be on, and that there are medications that are risky, and there are medications that aren't. Aspirin, of course, is one of the medications that if you don't have heart disease, you shouldn't be on aspirin, because aspirin, in addition to many other things, is increase the risk for bleeding. So it's very helpful in terms of preventing clots, but it also increases the risk of bleeding. So if you have no reason for it, then you shouldn't be on it. But if you have arteriosclerosis, then that's a reason to be on it. But there's so many questions about the safety of aspirin, particularly if you don't have arteriosclerotic disease. And the risk versus benefit is greater for risk if you do not have arteriosclerotic heart disease.
Dr. Callender, I think we have an article coming up that shows that aspirin.
Well, that's a different article, but that's separate. But the point is that aspirin, if you don't have arteriosclerotic heart disease and you take it, it can increase the risk of bleeding, and that's important. You're right. There are the uses of aspirin, and we'll talk about that. But this is a subject for which many articles have discussed the risk-benefit ratio of taking aspirin, not taking aspirin. And then as you see here, there are other medications like warfarin and other anticoagulants that are important to reduce the risk of clotting, because you don't want to have a clot and you don't want to bleed. So you got to have a medium where you don't bleed and you don't have a clot. And so sometimes it's a risky, it's a line that you don't want to cross unless you have to. But if you have clots, then you have to take anticoagulants, because clots kill you. And you don't want to get to the point where you bleed, because bleeding kills you. So it's a line that you have to walk carefully. Talking about the antipsychotics, and the concern is that antipsychotics sometimes can increase the risk for stroke and other things like that. But if you have psychoses, then these things are worth the risk. And then, of course, benzodiazepines, which we talked about earlier, increase the risk of falls. Falls get you fractures, and fractures kill you when you're over 65. So these are drugs that you should only take if you need to have them, and you should take them for a limited period of time so that they don't cause you to fall and cause you to have fractures, which may cause you to have complications that result in death. Then non-steroidals, when indicated, are good, but if you take them forever, they give you kidney disease and many other problems and give you ulcers as well. So these are some of the medication that you have to be sensitive to. If you have a reason to take it, yes. But if you have to continuously take it, then it has side effects that you have to be aware of, particularly if you're above the 65-year-old group. Then he lists some of the other things that we've talked about before, the diabetic drugs, the proton pump inhibitors that we talked about before. The digoxin is not something that we've talked about, but it plays a role in some people who have heart failure. So, and then nitrofurantoin is a good drug for kidney infection, but it also is nephrotoxic to the kidney, so you have to be careful about that.
Yes.
And then the anticholinergics, scopolamine, diphenhydramine, these other medications, when combined with other medications, can dry you up and cause all other kinds of problems. So the moral of the story is that if you have a condition and requires treatment, that's fine. But if you can avoid being on a medication, you should do so. The fewer medications you're on, the better off you are. On the other hand, if you have a problem and it requires treatment, then the risk versus benefit ratio is important for you to take the medication.
I have a question, Dr. Callender.
Yes.
The NSAIDs, would that include meloxicam?
What drug is that?
I think it's called meloxicam.
I don't know what that is.
It's a muscle relaxant. Or are there any other of those non?
That's not an NSAID though. The NSAIDs are Motrin,
okay.
Aleve,
Okay.
Aleve, and those are the NSAIDs. That name you mentioned is not one that I'm familiar with.
Okay. It has another popular name. I'll remember it later. I'll ask you offline.
Oh, okay. But that name I don't recognize. Okay, any other questions or comments? This is a very important topic. Okay, right. This is something that we becoming more and more understanding of, and I love more why doctors should promote social connection. We recognize that contact, when we talked about the companion robot, what we were talking about is the need for social contact. And the fact that doctors should be talking more about increasing social contact. And social connectedness is what it's actually what it's called. And love more is a term of saying that we should be interacting socially with one another. And I think that that's something that doctors should encourage. We tend to talk about things that increase the blood flow to the heart and reverse the narrowing of arteries, diets, and so forth. Sometimes we don't talk enough about the importance of support groups like one we have here, and the importance of being able to talk openly and disagree in a friendly fashion. And this is then therapeutic. This, along with learning to love yourself and love others as you love yourself. Important. It's interesting because we talk about it's better to give than to receive, because in giving you receive. It's in giving that you receive. It's in pardoning that you pardon. It's in dying that you're born to eternal life. So that giving and loving is medicine, and loneliness is the antithesis of loving, and that begets the public health crisis which we have, where loneliness, isolation is rampant. And so what they're suggesting is, as physicians, we should talk more about the need for social interactions and the need for addressing loneliness as a stressor. We talk about racism as a stressor. Loneliness is another stressor, and none of the stresses are good, and that's why mindfulness and other things are now becoming part of what we call healthy lifestyles. Plant-based diets, meditation, all of that. We tend not to talk about the importance of meditation and mindfulness and those kinds of things. And we're more likely to talk about plant-based diets than we are to talk about meditation and all that. But being a good doctor requires you to recognize the importance of love, and loving yourself and loving your neighbor. Any comments? Because this is an important aspect of healthcare that sometimes we take for granted. And as physicians, we really seem to recognize and to promote the social connectedness as much as we should. Any comments or thoughts about that? No comment. Okay. Now, this is something that was surprising to me, because when people are dying, most people aren't thinking that sex is important. But on the other hand, how do you know unless you really talk to people who are dying? And this in palliative care came to the forefront because they did ask patients. And when they brought it up, they were surprised to find that sex was of concern to some. But if you never ask, you never know. And so talking about sexual orientation, body image, and gender are topics that are not forbidden for people who are dying. Although I'd never thought of it before in that fashion. But it's part of your psychosocial well-being, and it's really food for thought. Anybody else have any ideas on this subject? I had never even thought about it before, and part of palliative care. But what are your thoughts about it?
We have talked about how STDs have increased in nursing homes. We've talked about that before.
Yeah, nursing home is one thing. Palliative care is another. In nursing home, you're right. That points out how important it is to talk about sex for the people who are over 65 and 80 and 85 and 90. But palliative care, you almost think of people who are dying, and what do they care about sex? And lo and behold, they do care about sex. But we never talk to them about it, so we don't know. So and it never occurred to me that this was a topic that was of germane for somebody who was on palliative care and was in hospice. Had any of you thought of that as a conversation you might bring up or talk about?
I have a question on palliative care. Are the people physically able to have sex?
It depends. Some people are, some aren't. It varies. Some people are so sick that they can't, but they still may want to talk about it. The question is some can and some can't. You have some people who's so sick they can't hardly move. You have others who actually can walk around, and it's not necessarily that they can have sex, but they may want to talk about it, even if they can't perform.
Okay, and wouldn't the fear of someone dying while they're having sex come into the play?
Well, I think, and I think this is something, I'm glad you brought that up, because this is something that would be their choice. Whether or not that is something that would be in the forefront of their minds before they pass on. Because of the fact that it has not even been addressed, it's hard to say.
And
Well,
I don't remember dealing with my mom and having to speak with a palliative care nurse. They had a whole staff there, sponsored by Kaiser. Her mind was going, but her body was, completely okay. So there, I can imagine there are situations when someone is dying, as with Alzheimer's or mental disorders, that their physical abilities remain intact. I'm just thinking that those two things can be separated.
And the ability to have sex and the ability to want to have sex may be two different things. And so the question is the sexual discussion a topic that we are willing to talk about at the time of death and the time of palliative care? And the real answer is that we have rarely crossed that barrier, because we have often have been reluctant to even put sex in the conversation. And this article is suggesting that this is a topic for discussion, even at the hospice level.
Dr.
Yeah,
Callender.
I think it's great that the sex is finally, well, that it could finally start to enter the conversations. And long before it gets to hospice or end of life issues, that should be part of the conversation just with regular care. Like right now, one of the questions that has become a part of regular conversation, whenever you go to the doctor, they're going to ask you, have you been depressed lately? Do you have any suicidal thoughts? And so now depression and mental health has become accepted conversation. But I'd love to see sexuality become accepted conversation in regular care at all ages.
That's what they're suggesting. Yeah. Any other comments or thoughts on the subject?
I think it's happening at all levels, doctors. That's one of the, especially when you're getting a physical or something, the doctors will ask you, how is your sex life?
But that's when you're healthy. But we're talking about if you're in hospice and you're in palliative care.
All
that's
over.
where it's not been part of the conversation, and what they're suggesting is that it should be.
Dr. Callender,
Yes.
back in the I think early 70s, that book came out, whatever you wanted to know about sex would, but were afraid to ask. And I had a very good friend who was in the hospital and she had leukemia, and they had just told her that she had less than 6 months to live. She did live a little longer, but she asked me to bring her that book. And it was a quandary on both parts because I was scared to buy it, but she wanted to read it, so that gave me courage to go and buy it. And to look for people when I'm standing in line with that book and looking at the people looking at me. And, and I swear, when I bought that book, that man held that book up in the air like it was a Bible. And before he put it in the bag so that everybody could see what I was buying. So I took the book. I took the book to the hospital, and she and I sat up there and we read the book, and the nurses came in and they gave us dirty looks. And her mother came in and she was upset. Now we were I think I was probably 18. I think she was 20. So she was telling me, she said, they're looking at me like that because they think that I'm going to die a virgin, but I got news for them. And she said, I'm going to get out of this hospital. And so she did get out of the hospital, and she did, we did start venturing out, and she met a guy and they had a good relationship. She lived for 2 years.
Wow.
And she died. She had gone to North Carolina because she had taken up bowling, and she was in a tournament, and they had won the semifinals, and they had gone down there for the finals. And she died the night before they were going to have their their final bowling pageant. But what that to say is that they thought she was on her deathbed, but she had other thoughts in her mind. So when you said that, it made me smile, because a lot of people gave me grief for doing that at the time.
Thanks.
But I didn't care, because I felt like if she wanted to do it, I would help her do it,
Thanks for sharing. What a story.
Dr. Callender, I too have another story that relates to that. I was directing a senior choir in the 80s, and it was one lady that needed a ride, and lived in Upper Northwest. And she told me, Sister Tatum, I may be old, can't hardly see, can't hardly walk, but the metro bus drivers obliged me greatly, and sort of shocked me. And and then some other women, the older women, they felt sort of free about talking about it, even with younger women. And they would just say and I was going to ask, has this investigation thought about, which they don't talk about, but I found out some older black women talking about their sexual toys that kept them happy, as you could say, or if the batteries ran out, they would go and get some more. But have they ever thought about that for the people that are in palliative care?
Well, I think that's a great point. I think if they haven't, they should, because I think that's a part of the conversation that needs to be had.
Yeah,
Thank
see,
you for sharing that.
the problem is the kids and the grandkids, because they get the attitude when they walk in grandma's room and all the toys are on the bed.
Okay. All right. You skipped an article, didn't you? Was there one?
Oh,
Was
and
the one
just
before
one more
that?
thing, you had two articles that relate, people needing love. And I know it may not seem they relate, but people by themselves and not interacting with other people, not receiving love, and not fulfilling their sexual needs, because we're sexual human beings from the moment we're born until the moment we die, but people do not like to talk about that.
And I think that's the whole point. Thank you. Thank you. Okay. Yeah, this is the other article that talked about a new use for aspirin. We know of aspirin for many reasons, but this is a new finding that aspirin reduces liver fat. We've talked about non-alcoholic fatty liver disease, and which is reversible. And so here's a treatment for it, because non-alcoholic fatty liver disease is reversible, but non-alcoholic stereotypic liver disease is irreversible and requires liver transplant. So at this stage, when you have a non-alcoholic fatty liver disease, that's the time when low-dose aspirin has demonstrated that this decreases inflammation and fibrosis, which then means that you could prevent from going into the steatotic, what we call NASH, NAFT, and NASH. And NASH is the one that is associated with needing a liver transplant and developing into cancer. And so this then is now a new indication for aspirin, although, and this is something that nobody has talked about the side effect of the aspirin causing bleeding as a side effect, but it certainly is another indication for the use of low-dose aspirin. As I'd mentioned before, the NASH is going to be perhaps going to be, it's called steatohepatitis, which is the term for NASH, is going to be one of the leading causes of liver failure and the reason you need transplant. So this then is another use for aspirin that we hadn't thought of before. Any other comments about this? This is an interesting development because really there was no, the only treatments that we had before for reversal of non-alcoholic fatty liver disease was control of diabetes, reduction of fat intake, and now we have low-dose aspirin as an additional treatment. Okay, any comment on that? Any additional comment on that? Okay, now this is something that is not unexpected, and that is the increase in flu and RSV. I don't know how many of you have you already gotten your flu shots and your COVID shots, and also your RSV shots. So now's the time, actually, because December is tomorrow, and the flu season is upon us. So now's the time to make sure you get the shot.
Dr. Callender, I have a question about the flu shot. My GP gave me a regular flu shot, and now I think you've answered this before. Should I go ahead and get the senior flu shot, or isn't that too many flu shots for one person?
Well, the truth of the matter is that the regular shot is not potent enough for people who are over 65. And so, question of whether you should get another shot, assuming that you're going to get the high potency shot, because the thinking is that the regular dose shot is not strong enough for people who are over 65, and that so my advice is would be to get another shot, to get the high potency shot. There's no point getting the same shot over again, but if you get the high potency shot, it's worth it.
So that means I would get 1.5 shots of flu.
No, I mean, you get 2 shots.
Okay, I already got the mild one, so I got to go
That's
now
right.
and get this high potency one.
Yeah, right.
Okay.
That'd be
They
my
got
advice. But I would say to you that hasn't been a lot of discussion about that, and there's a lot of not a lot of data. That's why I emphasize, because most of the doctors, I was disappointed to see that most of the doctors were not giving the high potency shot to the older people, and people presume that your doctor would do that, but in far too many instances they are not. I know I always ask for it. I suggest you ask for it, and the fact that there is a high potency indicates to me that there's a difference between the two, and therefore, if you don't have it, then you have not gotten what you need to get if you're over 65. And the closer you are to 80, the more you need that extra potency. If you're borderline 65, 64, maybe it's not as important, but as you go more towards 75 and 80, then I think to me, it's worth taking. But I don't know any article that has discussed that topic. That's what I'm saying, that most people would just go and get the shot and don't ask about it, and they don't realize that they have been underdosed. But yeah, you ask me a question, my answer is I'd get the additional shot. But there's no point in you getting the same shot. You got to either it's the high potency shot or don't get anything else. Yeah. Has everybody gotten the COVID shot too?
Yes.
Okay, good. Okay. RSV now is available in most places, so I guess that's the other one to get. And most people already have the pneumonia,
Shingles.
and the shingles, right? Okay.
Dr. Callender, Saturday, I'm going to get 3 at the same time: the high dose flu, the RSV, and the COVID.
Okay. Well, you can see this article is indicating that the flu season is upon us, so now's the time. How long does it take after you get the shot, before it protects you?
2 weeks.
2 weeks.
Yeah, 2 weeks. Okay. All right, let's go to the next one. This is the new variant that they're talking about, whether that is going to the fact is that the virus will protect against it. The question is, as you go about, are you being protecting yourself as you go into the closed sessions, meetings, or when you go into airports, are you masking? And it's still something that in the grocery stores, you're seeing more people with masks, but not nearly as much as we used to during COVID. So, and the expectation is that the vaccine is protective against all the variants so far. So,
Dr. Callender, I wanted to report that I had a cold after coming back from Mexico, and the cold is a virus as well.
right.
But I tested like 6 times to make sure it wasn't COVID. But symptoms were mild, mostly nasal congestion, maybe a little cough, no fever, anything like that. But I had a cold, a regular cold.
Right. Old common variety cold.
I'm glad it wasn't worse than that.
Yeah, okay. Let's go to the next article, please. Well, this is an interesting article that compares California and Florida. As you know, Florida has an older population, and California is thought to be a younger population. And of course, we know Governor Ron DeSantis had his own ideas about how you should get the vaccine or not. And what this article says is that the California people, for the most part, fared better than the Florida people. Much of that is thought related to the fact that the population in Florida is older than the population in Florida. And so the battle rages on, and this is a long article that talks about the death toll and tries to identify. Now, both of these are warm climates, California and Florida. But when you look at all of the data, it seems that Floridians had just a slightly higher death rates. And I don't know what it means, because we do know that the booster capability differed. And many more people had boosters in California than they did in Florida. And that was the reason that many thought that the morbidity rate in California was lower than Florida. But as you look at all these different numbers, it really becomes more confusing. But the real gist of the story was to suggest that the lower booster rate for Florida was the reason that Florida had a higher mortality rate than California, although there's so many more variables.
Dr. Callender, does the COVID virus survive better in warm climates than cold climates?
I have no idea. I haven't seen any data on that. But that makes a difference. I haven't seen data that made a difference.
because I know bacteria likes moisture, darkness, and warmth.
Yeah. Well, I don't know the answer for that relative to COVID. But I would say this, that it does seem so far that the COVID rates have not even been discussed recently. Talk about the flu and RSV, but not COVID. Listen, I like cantaloupes, but looks salmonella tainted cantaloupes is something that let's go to salmonella outbreak. 32 states. Let's see that I didn't see whether they included DC or Maryland, but they did mention 32 states. But I guess they'll be leaving it alone for a while with the fear of these kind. Yeah, they don't mention Arizona, Missouri, Minnesota, Wisconsin, Ohio. They mention. They don't mention our areas. But I'm sure that those who eat cantaloupes will stop after this for a while. Official advice is to throw it out. So those who love cantaloupe do it without it for a month or so. It's interesting on them 10 foods to eat when you have the flu and foods to avoid. Very nice article talking about staying hydrated, which is very important. And it also talks about it identifies the soups and other things that you should have. Very nice article that talks about broth, ginger tea, herbal tea with honey, lemon tea. Then it goes on to talk about specifically those foods to eat and those foods not to eat. And of course, broth, number one, chicken soup. Garlic is interesting that it's always on every list of 10 vitamin D foods. Good old yogurt and probiotics, which we talked about before. And then vitamin C foods. Good old greens. Of course, broccoli, which Daryl does not like. Right, Daryl? Because it's hybrid, I think. Oatmeal and spices. I think turmeric and ginger. Oh, we talked about before, excuse me. Then there's a list of foods to avoid. You can see there. They include milk there. And last but not least is processed foods. It's a very nice article that cuts to the chase. Here's a nice group of products here. I think it tries to answer all the questions, whether you agree with it or not. The bottom of that line, it's always with everything is stay hydrated. And these are the list of foods you need to avoid. So it's a good reread article. It's nice. Covers the waterfront very nicely. As is this article that talks about 10 healthy habits that take less than 10 minutes each. And it's very basic and very simple. Talks about vitamin supplements, vitamin D supplements, and many articles that say supplements are a waste of time. But anyway, one thing that's inviolate is to drink plenty of water. And then it talks about breathing exercises, mindfulness, 10-minute walk. Outside is better. And then, of course, exercise reduces the blood pressure. Socializing improves mental health. Talk with loved ones helps with depression and anxiety. And then eating a meal mindfully is an interesting way they talk about mindful eating. And then practicing gratitude for 10 minutes. And then writing down goals, brushing and flossing your teeth daily, which is important. Washing your face, going to bed earlier. And then relaxation techniques for 10 minutes before bedtime will help you sleep better, they say. So, anyway, these are nice little helpful hints that won't hurt and might help. We've talked about sand forever, but this article talks about the ways to diagnose it and to treat it. The fact that it occurs more commonly in women, that only 5% of the population suffer from it. It's really a depression that is associated with shorter days, shorter sunlight. Cause it's really not known, although people will tell you that melatonin helps. And you see this long list of contributory factors. That when you have that many, you know that we don't really know what's causing it. But we do know the symptoms. And they're pretty much listed here. All of these fit. Most people don't have all of them, but they have some. The extent to which you have depression depends on many things, and whether you become suicidal or not is another issue. And the treatment, of course, is to get mental health treatment, psychotherapy, antidepressant medications, and increase exposure to the light while the light is there. And then the same healthy diet that is always recommended: exercise, stay engaged, and avoid drugs and alcohol, and do things that improve your mental health. I think these are the things that may be helpful. most of the people have said and really don't seem to get better until we get more sunlight.
Dr. Callender, that's why I believe the circadian rhythm has a lot. I That's what I think. It has a lot to do with it, the disruption of the circadian 30-day pattern, with the amount of light that goes along with it. The less amount of light, I think it's probably that's just my observation over the past 20 years of living with somebody that has it.
Mm-hmm.
They use a light box. That seems to help, but that light box, even though it's nice and bright, it's not the same as sunlight. Sunlight is special.
Yeah. Okay. My wife has it as well. Oh yeah, there's been a wave of eye drop calls because of the infections, and still people who have dry eyes still need to have eye drops. So you have to get products that are safer. And this talks about the fact that there are safe eye drops. And in this article, this artificial tears and some other things that have been removed from the market. The question is, how do you get eye drops safely these days? I mean, using contaminated eye drops is more than the notion. Can you imagine going blind because of the eye drops? They recommend come to your local eye doctor to find out what is safe to use. The Velocity Pharma was the one that they identified, but those of you who take eye drops should talk to your optometrist to be on the safe side. It's kind of horrifying to think that eye drops cause you to lose your eyes. Wow, really sad. So many things we take for granted that are safe that aren't safe.
I have to use eye drops every day, at least twice a day. A dry eye.
This is an article that I thought of Daryl when I read this article, because it talks about how great you feel after you do cold water swimming. And so far, Daryl's the only one I know who likes swimming and likes taking these cold showers. And but this particular person who writes the article says the tremendous mental health benefits are so great that it's worth it. Anybody else who is cold water enthusiast? Well, we know Daryl has proclaimed it time and time again, and all of the evidence seems to point to the fact that it has a lot of benefits. I have trouble even taking a cold shower, not speaking diving into cold water. It's amazing how those people who do it really rave about it. And
Well, the other thing is ice baths. Like after I finish a
ah,
marathon,
ah, oh my
yeah, after
goodness.
after I finish a marathon, I get a bunch of bags of ice. Uh,
Oh no.
I don't know, maybe about like three 20-pound bags, put it in the bathtub and
No.
sit in the bathtub for about an hour. And
Woo!
it's wonderful because like after a marathon, without that, you have problems walking that evening. But after you, after that ice bath, after a marathon, you can go out dancing that night.
Well, it's interesting. Everyone who does it raves about it. So, what can you say? The thought of having those ice bags in the bathtub.
Yeah, but
It's
the way
quite
you do it is you put the ice in, you fill up the tub up with water, but it's more ice than water, and then you just jump in.
woo! Wow. When you jump in, what's the first uh, response of your body?
Oh, S word.
uh, but the after is so great that it's worth it.
Oh, you get used to it right away. It's very similar to just jumping in a pool of water when you're swimming in the
Yeah,
summer. You
yeah,
know, it seems cold at first, but
yeah,
you just jump in, get it over your head, and very quickly you're fine.
yeah, yeah. Okay, okay. All right. And this then, of course, is an article that tells us what we already know, that life expectancy can increase 10 years if you adopt a healthier life diet. This is demonstrated in the UK, but there's so much evidence that this is what is killing us. What we eat is killing us. So the healthier we are and what we eat, the longer we live. I think that the evidence is overwhelming. So we have articles all the time that show us the data. And, but this is particularly for UK, but it's probably the same everywhere. The less, the less, the more fruit and vegetables you eat, uh, the less meat you eat, the better off you are. I don't think there's much uh, reason to debate the issue, but maybe there's some do. But the data is so strong that life expectancy can be improved by healthy diet. Of course, that's easy for us to say that I've reached 65, but we see so many people who are dying under 60. And the data is so strong that it's amazing that some people still have unhealthy lifestyles because they got used to the taste of food. But I think the take-home message is the same everywhere. Less sugar, less salt, more vegetables, more fruit, the longer you live. But who wants to live forever? Everyone. Look, listen to the conclusion. This is interesting. For about 3 years, with the least healthy dietary patterns, and with the greatest 10 years. So if you want to live 3 years longer or 10 years longer, change your diet. Whole grains and nuts, reduced sugar, and processed meats. It's pretty clear, isn't it? Okay. Let's go to the next one. Now, it's interesting that the ransomware attacks are everywhere. We've had it here and there and everywhere. And, all hospitals and colleges, the government itself, have all been associated with this. And they've made millions of dollars of this. Is the end in sight? I doubt it. People still pay though. They ask them not to pay, but they still pay. Now I know that Howard University didn't pay. They had their hackers. So they did not pay, but some people have paid. Okay, there's not much we can do about this. It's an interesting article that postpartum depression. I don't know how many of you mothers or your children have had postpartum depression, but it is a problem that is more evident than we seem to know about it. And the mental health that was provided by these people in Utah and places where they have groups that work with women who have postpartum depression and avoid the stigma of postpartum depression. It's something that is remarkable. I think this article points out how the community in Utah, they call it the Sad Moms Club, worked to provide the mental health that was necessary to get people help. We had one of our residents delivered who had postpartum psychosis. As a matter of fact, the resident's wife has postpartum psychosis. And it was a cause of desperation and concern. She finally got the mental health she needed, but it was difficult. And it's sometimes it's hard for some others to think that postpartum depression is a reality, but it's very common and very devastating. It can be a cause for suicide.
It's the last
Any
article.
comments?
I'm
Okay.
reading from the National Library of Medicine where it says that in their studies, 9% of white women had postpartum depression, 4% of blacks, and 5% of Latinas. So
Interesting,
I'm
yeah.
rejoicing in the fact that Black's got a good number going on.
Yeah, finally. Yeah. Yeah. This is the last article. This is an article. Wow, I realize it's 10:30 already. Short naps are good for you. Long naps, they say, aren't. They talk about naps of less than an hour, preferably about 20 to 30 minutes. Are you a napper?
I am.
Yep, getting ready to take one right after this group session.
Okay.
Only if the sermon is boring.
uh,
Or if you eat enough turkey.
Which is a good reason to go to church, because that way you can get your rest.
Oh no.
But what if it's a 40
Daryl,
minute,
you
if
didn't
it's a
say
40-minute sermon, yeah, that's too long.
that. Daryl, oh my goodness. How could you say
Pastor
Just
said,
play solitary.
Oh, you see me do that, huh?
Yes.
Pastor said, wake that deacon up. He said, I ain't waking him up. You wake him up. You put him to sleep.